Hi, my name is Laura Edgar. I am the Senior Vice President for Competencies, Milestones, and Faculty Development here at the ACGME, and I am here to talk to you about good assessment. This session is really sort of some pre-learning for you before I make my visit in a couple of weeks, for which I'm really looking forward to an opportunity to do some deep dives into the assessment tools that you currently have. This session will be about 45 minutes, and we'll have plenty of opportunities to review. I'll answer questions at the end of the month when I'm there with you. So let's go ahead and get started. I am going to go ahead and share my screen here first. And here we go. So what constitutes good assessment? It's really easy to think about doing assessment and, here we can do this assessment, we can do that assessment, and we'll just figure it out. We'll move forward through it. If a completed assessment is a good assessment, not necessarily. There are actually some very basic sort of ideas that we want to make sure we keep incorporated. So let's go ahead and dive in, shall we? So first of all, we want to think about assessment as part of a system, right? And when we really think about it, the assessments that you do within a program are really a way that you are going to help pass judgment about those learners. And that information ends up being part of what happens for the accreditation and the certification bodies, who are, of course, ultimately responsible to the public for making sure that you are practicing safe, effective practitioners, right? We want to make sure that the folks that we are graduating from our programs are, in fact, doing the things that we need them to do. Now, we have lots of opportunities for assessment in our programs. We don't always take every opportunity that we have, but there are quite a few out there. Now, you probably all know Miller's Pyramid at this point. At least I'm assuming you do. And essentially, it's the knows how, shows how, and does. And when we think about the types of assessments that we use, you can see here, multiple choice questions for the knowledge base, diagnostic reasoning and oral exams for the knows how, standardized patients or simulation for shows how, and finally, the multi-source feedback and direct observation for the does, because of course, the does is the piece that we really want to make sure that we're able to assess, because that's the ultimate piece that we want to make sure that we can see. Now, we know that workplace-based assessment is mostly done through this method. And we want to make sure that we're doing this and we're measuring in each of these areas throughout the time that our learners are with us. And there is a tendency to start to move a little bit more away from the knows and the knows how as our learners get more advanced in our programs. However, because of course of certification exams, they do still have to maintain a lot of that core and basic clinical knowledge that they have to be able to demonstrate. And so I want to encourage you that really throughout the time that they're in your program, you want to continue to measure capacity, capability, and ability in action. Because really what you're wanting to do is you're wanting to measure their performance. Because if you're not focusing on their performance, it's going to be really hard to get to this area of competence. Now, when we're thinking about assessing performance, there are a lot of different influences that can impact what it is that we're seeing and what it is that we're measuring. We're going to talk a little bit about what some of those are. In the end, context matters. There are a couple of things that I spend a lot of time talking about, regardless of my topics. Just about anything I mention related to milestones, clinical competency committees, competency assessment, two of the things are context matters and shared mental models. Those really are two important ideals that I want you to keep in mind throughout all of the work that we're going to do together. What's interesting is that over time, things change. And so Miller's Pyramid has added a new fifth level. It wasn't so much Miller who did it. It was done by some folks in medical education. And they added this element of trusted. So trusted with future care. And so essentially what Ole Tenkat and others have sort of put forward is this idea that we've already measured that they can do something, right? They can perform an action, they have the ability in action to do it. And now we are at a point where we trust them to do this work without us, right? We trust them with future care. Now, whether that is while they're still in training with us or after they leave our program, I think that depends on the individual activity that you're talking about. Now, this is a list of common assessment tools. It's just a list. I wouldn't say that there's one that is always better than another. Again, context matters. It also depends on the knowledge and the abilities of the faculty who are using those tools. Because just like the fact that your learners are trying to learn something, your faculty have to learn how to use these tools appropriately. If you have not trained your faculty in how to use the tools that you're using, you could be getting wildly different results. You could be getting inaccurate results simply because they don't understand the tool that it is that they're using, or they're misunderstanding the tool that they're using. They're making an assumption that it means X and that they should be watching Y. And in fact, you want them, it means A and they should be watching B. And so it's going to be really important that you think about how it is you're going to create a shared mental model with all of the faculty around each of the individual assessment tools that you're using. So how do you choose? Right? You've got all these different types of tools out there. Maybe you have a lot of different tools that you could use. So how do you make the decision of which one to go with? In the end, nothing's perfect, right? You have to look at the pros and the cons of the individual assessment tools. There's no, like I said, no right or wrong answer, and you have to just figure out what is going to work best in an individual situation. This idea of fit for purpose is really a nice way to think about what it is that you're using. Essentially, you need to find a tool that is going to measure what you want it to measure in the space in which you are trying to measure it. And I think the slide really kind of covers it well. Is it the right tool for the right competency? Is it going to give you good feedback on the development of the learner? And how does it fit within the overall program of assessment? You don't want to have a tool for the sake of having a tool, right? An assessment tool that just sits on the shelf is of no use. An assessment tool that is just an add-on and doesn't provide any additional information for the learner, it becomes something that is just going to be an add-on, and your faculty are probably not going to use it. The other thing to consider besides fitness is validity. Now, Messick is one of the people that thinks a lot about validity, and it's basically the degree to which empirical evidence and theoretical rationale support adequacy and appropriateness of interpretations and actions based on test scores. That's a lot. Essentially, we want to make sure we're using a good tool that basically we can find if, when there is variance, we can understand where the variance comes from. And we have to understand the consequences of the assessment. If there are no consequences from the assessment, then why are we doing it? If the assessment doesn't give us anything back, if it doesn't have a change, doesn't cause a change for the learner or for the program, then there's no point in using it. There is no construct validity to it then. So essentially, Messick talks about 5 areas. Talks about content, response process, internal structure, relationship to other variables, and outcomes. And if you don't have each of these things considered, if each of these pieces aren't included, then you've got a tool that is going to fail. And then I think this really kind of simplifies the whole thing when we think about reliability, because of course this, you can't have validity without reliability. And when we think about reliability, we want to make sure we have each of our raters have to be consistent. They have to be consistent over time, and they have to be consistent over items. And another way to think about that and these two items together is right here, right? We definitely don't want the first one. The second one can lead to a lot of bad decisions. And of course, reliable and valid is what we actually want. Now, we're going to move on from validity and reliability to utility. And utility kind of gets us back to that idea of fit for purpose, right? Because if you have something that doesn't have good utility, then it's, again, going to be an assessment tool that is going to fail you. Cees van der Vleuten actually created this equation that we can use. And one thing to keep in mind is because it's an equation, what happens if any variable within an equation is zero? In a multiplication equation, your answer is zero, right? Which means that you have no utility. Now, in this case, just very briefly, validity and reliability, we've already talked about. Acceptability means that essentially the faculty have to accept that this is a good tool. They have to accept that they're going to use this tool. Your learners have to accept that the results are going to be impactful for them. The educational impact, again, consequences, right? There has to be something that comes out of this, the results of using this tool, that are going to make a change, that are going to cause the learner to realize that where they are in a particular skill or piece of knowledge or ability, they're going to know what it is that they have to do to improve. Something has to have an impact, right? It has to cause a change. And then finally, the cost effectiveness. If you have a tool that is going to be too expensive to put forward or to use, that's something that, again, is going to be really difficult for you to implement and then to keep carrying on. We can't use high-end simulation for everything, right? Simply because of the cost. In 2018, they came out with this idea of a framework for good assessment, which is actually not too terribly different from what we just saw from Cees van der Vleuten. I think the big difference that they added in here was this idea of equivalence and catalytic effect. The catalytic effect is really that it's going to be something that's going to have more motivation for change, and equivalence is going to be, it's more than just reliability or consistency. It's that you are going to have equivalence over time. Right? In all of these cases, though, you can see feasibility, catalytic effect, acceptability, validity, and reliability. Your faculty are really important here. If your faculty are not well trained, again, these are going to be areas that are going to fail. So just a little more about the educational effect and the catalytic effect. Just some quotes from Norsini, who led the work back when these things were first being started. But we also have to think about the amount of assessment that we do, right? Quite often, I have seen programs where they use 1 or 2 assessments, and they're making big decisions from that. And that's actually not very effective. Now, is this kind of, I love this little graph because I think it's a great way to think about it. If there are no stakes, right? If you're simply trying a yes or no, they can do it or they can't do it, one test, one assessment is going to be fine. But if you are trying to make a big decision, promotion, right, from PG1 to PG2, you should have a lot of data points. I like to think of this acronym. I say the MAMAs, the multiple assessments by multiple assessors in multiple scenarios, right? So you can't just do assessments in one place. You have to have multiple assessments across multiple situations, multiple places. The more you have, the more likely you are to see enough to be able to make a valid assessment. Now, one of the issues that we run into with faculty assessment is this idea of rater cognition. We often don't think about this. This is one of the things that we sometimes, I think, are pretty blind to. And so we're just going to spend a few minutes thinking about how we might think about this further. All of the assessment work that we do happens in various systems, right? We are teaching our residents in a very complex system. And what ends up happening is that our faculty develop this lens through which they are going to assess their learners, right? They're taking care of their patients, they're watching their learners take care of patients, and they use this lens to be able to monitor them. Well, that lens usually has a lot to do with self, right? They're thinking about how they would do something. They're thinking about how they would manage a particular patient presentation. And that lens can often lead to changes in the way that somebody is assessed. It's not necessarily that the person did something wrong, it's that they didn't do it the way that the faculty member would have. Now, some of the individual factors that can affect assessment, there's always psychometric issues. These are things that can come up. And I'm, by the way, going to talk a little bit about each of these. Variability among faculty, and then, of course, human limitations. Now, in terms of psychometric issues, one of the things that happens is that we'll see some big issues in intra or inter-rater reliability. And the first thing we usually jump to is, oh, we better change that tool. There's something wrong with the tool. Usually, if we look back, we haven't actually trained our raters on how to use the tool it is we're asking them to use. And that is, in fact, what has caused those changes. There's actually not been a lot of research that shows that changing the tool makes a big change, right? Unless you're using a big evidence-based approach, that's not necessarily going to fix your problem. A lot of it has to do with a lack of discrimination. There's this sense that if you're trying to observe a single competency or a single activity, quite often we tend to focus on other things. We get distracted by other things. And I like to think of that as, you know, we have these 6 core competencies that we're supposed to be thinking about. But there is a lot of overlap and a lot of, I like to think of it as the gray squishy areas between the competencies. Where does medical knowledge end and patient care begin, right? Where does communication and professionalism switch over? There is a lot of overlap, and sometimes one piece of the other can cause us to be distracted. And so we don't do a really good job of being able to focus on just that one singular activity. Some common rating errors that we have, the halo and horn effects, where these types of correlational errors are usually based on personality. You know, you meet a resident and you instantly like them, or you instantly dislike them. And what happens is that you're instantly biased. And so, you know, everybody likes this learner. And so everybody's scoring this learner high. Maybe this other learner, not quite as personable, and it's easier to score them low. I have actually seen this in action. I was observing a clinical competency committee for a neurology program. They had a senior resident. This was in the mid-year review. They had a senior resident that everybody was just glowing about. Everybody really, truly loved this resident. This resident could do no wrong. And as they were going through the milestones, everything was a 4 and a 5. I was thinking there were way too many fives. But that I of course wasn't a faculty member. And finally, there was one junior faculty member who had just started with that academic year, raised his hand and he said, you know, I'm sorry, but I've never actually seen the resident do a lumbar puncture, which in neurology is a milestone. And they went around the room and nobody had seen it. And they said, okay, well, you know, go observe her doing a lumbar puncture. And, you know, once you see, you'll see she's great. There won't be a problem. Well, turned out there was. It turned out that this particular resident really disliked doing lumbar punctures. And for the last 3.5 years, had managed to convince her colleagues to do lumbar punctures for her. She was terrible at them. Ended up having to have some remediation in order to get to a place so that she ended up at a 3 on her final evaluation. But for about 6 months, they had to follow her closely. Now, there would have been a real impact on patient care after she graduated had that one junior faculty member not spoken up. So the halo and horn effect, they are real. There's also what we call distributional errors, and those are the doves and the hawks, right? Those faculty members who think that every resident who works with them is just wonderful, fantastic, you know, 10 out of 10. They're a PG1 and they're a level 5 on the milestones, right? Then there are others who think that every resident who comes through isn't worth, you know, anything. They don't train them like we were trained anymore. And, you know, everybody tends to be terrible and, you know, they're just no good. And then we have the ones who like to straight line everybody. Every resident, regardless of what year they are, regardless of their level of experience, gets a middle of the road evaluation. None of those are good, right? All of those lead to problems when you're thinking about the actual assessment of the resident. And then, of course, we have bias and stereotypes, right? A lot of bias and stereotypes come from attention, impression, and memory, right? And they are really impacted by these external or internal, rather, pressures, emotion, time pressure, circadian rhythms, right? You take somebody who is used to working, who's an overnight hospitalist, and you suddenly switch them to days. That change in the circadian rhythm actually can cause them to be more reactive in terms of bias and stereotypes, right? And that's without any existing prejudice. It's just something that has been recognized as happening. There are, of course, cognitive preferences which can come up, but all of these things are going to happen, and they're things we have to be aware of, and there are things that we have to see what we can do in order to try to minimize them as much as we can. Because all of this is happening subconsciously, which is what makes it even harder, I think, as faculty members to keep this in mind. However, when we're thinking about our overall assessments, especially for those of you who are program directors or CCC chairs, as you're looking at assessments that are coming in, if you see some assessments that appear to be outliers, right, you might want to look at those and think about whether or not any of these particular things could have had the impact. There are lots of examples of bias, and when I say that they happen, I think subconsciously, even in things like the MSPE that gets sent from the deans, from the med schools. This was such a great study, you know, using words like exceptional and best for white applicants, whereas the word competent was used for Black applicants. Females are more often described as caring and empathetic, whereas male applicants were not, right? that's something we have to pay attention to. There have been milestone studies that have shown that there are differences in the way that milestones are evaluated based on race, where there are categories of underrepresented in medicine, where they are over time. A recent study by Dallin Boatwright in emergency medicine, where they were able to follow an entire cohort throughout their training, and over time they continuously stayed the entirety of their training. They ended up, that cohort stayed at the bottom of all of the ratings of milestones of the residents, and this is across the country. So it wasn't in a single program. It wasn't like there was just a couple of residents who happened to stick together, came from the same school, anything like that. This was looking across the country. And then other times we've not seen bias. So we know that, and that was, there was a study on gender bias in family medicine, and we didn't see bias there. So we know it's there. It's something we have to watch for, and it's something we have to be careful of. The other thing we have to be aware of is contrast effects. The order in which we watch different learners can actually impact how we assess each of them. In this particular study, a group of doctors, they watched 6 videos, and the order in which they observed these videos changed the way that they scored them. If they watched the highest performing videos first, the lower performing ones got even lower scores. If they observed the lowest performing one first, everybody else got even higher. And so it's just a really interesting way to think about it. But you want to be really careful if you are going to be observing multiple residents together. You want to make sure you're really randomizing the order in which you are observing them, so that you can try to avoid this contrasting effect. And then we get into human limitations. I know, we're all human, right? And this idea, this Miller's Law, is something that I like to talk about, because we are often, all of us, trying to multitask. And yet, our brains actually cannot do more than 7 plus or minus 2 things at a time. It's called cognitive load theory. Well, cognitive load theory is the other term for it. That's all we can do. Beyond that, our brains are actually unable to truly focus on them. And eventually those extra things become noise. Try and memorize. I want you to take a few seconds here and memorize these letters. All right, you got it? All right, go ahead and write those letters down. One of the things that happens is that when we see things, we tend to overestimate our abilities. And yes, I promise those are the same letters that I had just shown you. But what happens is that within our minds, we're able to organize things into buckets. And by organizing things into buckets, that's one of the things that allows us to be able to keep more things in our heads at one time. So asking you to remember individual letters, right? You can't memorize 20 individual letters, but by giving you a word, that word is one thing, right? It's not all of those individual letters. And this, again, this is all part of the fact that we have this limited working memory capacity. And within cognitive load theory, there's this idea that there are these 3 different types of loads. There's the extraneous load, right? Which this is the unnecessary and distracting information. These are the things that are coming at us from every different angle. There's the intrinsic load, and this is all the new information, right? So this is all the new things that are coming in. And then there's the germane load. The germane load is the part of the brain that is trying to connect all of these complex processes. All right. So This becomes really important when we're thinking about assessment. And it's also important to think about when we're teaching as well. When we're thinking about assessment, we can't try to assess too many things at one time. If we're trying to assess too many things at one time, it all becomes distracting. It all becomes extraneous, and we can't focus on what it is that we should be focusing on. There is some great research that talks about cognitive load in assessment in the clinical learning environment, and it really boils down to selective attention. If you're being given too much to do, you end up choosing in your brain, consciously or not, you end up choosing what it is that you're going to focus on. One of the things that we often see and hear about is that programs try to use the milestones as their assessment tool. Now, outside of a couple of the surgical specialties, they're really not designed for that. And in fact, if you're using the milestones as an assessment tool, you are causing a huge cognitive load to your assessors because those milestones are meant to be the bottom of the funnel, right? You should be doing other types of assessment throughout that time period that all feed into that actual evaluation. And so you want to think about how it is that you're going to create the synthesis of information, not trying to use the milestones themselves. The other thing to keep in mind is the length of your assessment tool. This, in some ways, goes back to the idea of utility, right? But one of the things that we know is that when you have a really long assessment tool, think about how frequently you get them back, or I should say, how frequently you get them back on time. Because by the way, that Miller's Law, that also applies to how long we remember things after the resident is no longer in our service, right? So if it's 7 plus or minus 2 days since they have worked with us, we've actually started to forget what it is that happened while they were with us. So keep that in mind too. But in terms of the length of the assessment tool, if you have a really short rotation, your assessment tool should be really short. And in fact, I usually recommend short evaluation tools anyways. But I've seen cases where they've taken 4 or 5 milestone sets and tried to use those as the end of rotation evaluation for a 2-week rotation. That is too much cognitive load, and it is going to be too much distraction for the evaluator to actually complete. And then we run into this idea of idiosyncrasy. And what happens with idiosyncrasy is that you could have multiple correct answers, right? It all depends on what it is that those different faculty know. It depends on when those different faculty actually see the resident in action, right? Depends on the setting or the situations that they see them in. In this particular experiment that was done, a couple of things to think about here is that, observing the resident in these different scenarios is really what is going to give you the best information. If you and another faculty member both happen to see the resident performing using best evidence, the best evidenced care, that's a great thing, right? That they're doing really good care. But until you see them, in these other situations or other settings, you have to keep watching them because you don't know when they're going out into these other areas. The zone of questionable or unacceptable care could be really close. That might be a razor thin margin between what is best evidence and what is unacceptable. If you're not paying attention, this is something that can be missed. And in fact, one of the things that I talk about quite often, and I hear others in assessment have started to talk about more, is this idea of going through and doing direct observation of things that maybe you haven't done for a while, like watching your senior residents do a history and physical, making sure that they haven't developed bad habits, making sure that they're actually doing a really good complete physical, when they should be doing a complete physical, making sure that they're getting all of that information that they should be getting from the history. You might be surprised what you see. So again, it's something I would recommend that you go ahead and try, because again, this is where you have that opportunity to actually see your residents performing in different ways. So because we're talking about limits of human memory, I want to give you a little summary of what we've just talked about. Remember, assessment is complex. It is not something that is easy. Rater cognition is something that we have to work on. We need to train our faculty, right? Doesn't fix everything, but it's gonna help a lot. We want to make sure that we know what it is that we're measuring for, right? We want it, what outcome are we actually looking at? We want to have a shared mental model about when we're going to use which tool and for which purpose. Our own clinical skills matter, right? If you can't do something, how are you going to really be able to assess your learner for doing it? Sampling is really essential. And we're going back to our mamas again, multiple raters, multiple assessments, multiple assessors in multiple settings. And again, you know, we know we're going to have some variation. We just want to make sure that we have some limits on it. So I'm going to talk to you about the last couple of things, and hopefully this will all make sense as I go through it. And again, we're going to be exploring all of this when I come back. You want to think about those different places that you're actually assessing your residents, right? Are you assessing them on rounds? Are you doing it? Is it a rotation based? Is it a patient encounters? Think about all the different places for which you are actually doing an assessment of your learner. If you have a rating scale, you really got to think about the challenges that you are putting in front of yourself. Do you have some clear goals of the rating scale? Is it standardized, right? What does this mean, right? Do you all remember? You probably all remember, you know, this Likert scale maybe when you were in school, and you know it had this sort of idea of unsatisfactory, satisfactory, and superior. But what really was the difference between 6 and 7? There was really never any explanation about this difference. And using this scale, a normative scale where you're comparing one resident to another resident, one learner to another learner, whose expectation are you exceeding? Whose expectation are you meeting, right? And did the expectation change from yesterday, right? So this still does not mean a whole lot. Because really what most of us do when we're using this type of a frame of reference, we're using this type of a scale, we're usually saying, you know, hey, if you do it the way I do it, then we're good, right? You've exceeded expectations because you do it my way, which can sometimes be a problem for the learner, because if they're working with 4 different faculty members in a particular rotation and each of the 4 do it a different way, they have to try to remember and do that performance those 4 different ways, depending on who it is that's assessing them or they're working with that particular day. And really, it comes down to Gestalt then, right? It's not a real assessment. It's that gut feeling that, oh, this is where they belong. What we really want to do is move more into an evidence-based assessment, right? If we're using evidence-based, we can say, hey, they're using all of the evidence-based, most of it, or they're missing stuff, right? Become something that's a little easier to not only use, but also to point out and share with the learner, say, hey, here's why you got the score that you got. But here's the big issue, right? Because faculty continue to use themselves as the frame of reference, this is going to continue to be a problem. And so there needs to be some training in frame of reference. There needs to be this shared mental model, again, about what it is that you're trying to measure, when you're trying to measure it, what exactly you're looking for, and when you're going to do it. And we can do that through construct aligned scales. Now, I'm not going to try and use a lot of medical jargon or educational jargon for you, but basically what we know is that when we have these construct aligned scales, when we have these scales that basically we have narratives, right? And they're aligned, they make sense, they're a developmental, we know that they're effective, right? And they can really help the evaluator to identify where the skills actually lie. And entrustment scales are just another construct aligned scale, right? It's another way that we tend to think about where it is that our learners sit, right? This is one activity. This is the Ottawa Clinic Assessment Tool. This group also created the OSAT, which is a surgical tool, which is a great entrustment scale and is so easy to use. And so if you see the 5 levels, I had to talk them through, I had to direct them from time to time. I needed to be available just in case, or I did not need to be there. These are some things that the faculty member, they're going to be able to easily identify which of those places they are. Now, where they sometimes get stuck is if they had to be there because of policy, sometimes they get stuck and they don't necessarily give those highest levels. But again, a little bit of training and you can usually get them to where they need to be. You can even change the scale a little bit on your mini CEX, right? You can change it to the learner can practice the skill with direct supervision or indirect supervision, or because of the CEX you're doing, you can get them to a place where they can do it unsupervised, right? Again, these are construct aligned scales, and these are things that are going to make sense for your faculty as well as your learners. Because in the end, a scale is nothing but a code. It's a translation of what it is that you're trying to tell them. But if you don't have a descriptive shared mental model about what that code means, you end up falling back to that gestalt or to that satisfactory, unsatisfactory, meets or exceeds expectations. So finally, as we kind of get into this last part here, as we rethink faculty assessment tools and our emphasis, we want to think about some things that you can do, right? I don't want to just tell you about that and then say, we'll figure it out later. I want to give you some tools and some ideas to think about before I come. And the first one is this idea of encounter cards or field notes. And some of you may have used them, and I will tell you, I think that this can be one of the places of the greatest information. Sometimes they're called shift cards, right? And this is essentially where in a day you can say, here's what you did well, here's what I want you to work on. I think that if you collect enough of those, you can get some really rich information. Now, here's a broader version of that OCAT score that I showed you earlier. And now you can see what some of the elements are that they're looking at for the clinic. Now, imagine if on a particular day, a preceptor or a faculty member that had worked with a resident was able to sit down and answer this very quickly. You probably know, right? You could probably do this in 2 minutes. It's not going to take a long time because by the end of the day, you know where they were in terms of their physical exams and doing their documentation, how collaborative they were, right? This is not something that is going to take a long time to complete. Now, this example comes from the Canadians. they've got some really great information that they collect here. Here's an example of a not so great and a good field note that's been collected. However, about 65% of the field notes that were collected, nobody put anything in the field note scale, right? And so again, I think anything that you use, it's got to be something that goes back to this acceptability idea. They have to be willing to answer all of the questions that you give them. You've probably heard this before. Narratives are the most powerful piece that you can have, right? You want to get narrative comments from your faculty because that's what really tells you what happened. If all you have is a number, so let's say on that OCAT, if all you had was let's say a 1 for physical examination, but there was no explanation about what the resident needed to improve on, if there was no note about what the resident did that was wrong, how does the program director or how does the next attending that has to work with that resident know what needs to be worked on? Right. And so you want to find a way that you're going to continuously encourage your faculty to provide this narrative comment. One tip I always like to throw out there is make your narrative comment the first thing that they have to put in and make it a required field. It's one way to think about it, or have that be your only part of the assessment, is that it is truly all narrative. I'll have more ideas for you when I see you. There's lots of research about how valuable narrative assessment is. As this one said, it can be extremely reliable even after only of several reports are collected. It's greater than 0.8 when 4 assessors' comments are included. So write those narratives. Work with your faculty to make sure that they're providing good narratives. One of my favorite things to do is to have your faculty 1 day a week spend 15 minutes with each of their residents and go through and do a feedback session. And it's something as simple as, here is what you did really well this week. Here's what I want you to work on next week. So not only do they have the conversation with the resident, but then they also submit that as an assessment for the week. If you do that each week, and you can even have it be guided, right? You can say, hey, this week I want you to specifically assess their ability to communicate with the team. I want you to assess the way that they thought about local population health, right? You can be directive in what it is that you want them to assess that week. Make it something that becomes regular. You could even put the onus partially on your learners, right? That they are responsible for going to their faculty member at the end of the week and saying, hey, it's time for my feedback session, right? I need my 15 minutes and, I need my form filled out. And this can be a really great way to start getting your faculty into the habit of providing that narrative feedback, not only to you as the program director, but also directly to your learners. Again, lots of studies that show how important and how valuable this narrative feedback can be. Now, one of the things that we have, is where we talk about the opportunity for equity pause and bias timeout. Getting that narrative description first, giving feedback to the learner, and then completing the entrustments scale or tagging it to the milestone framework. What that does is it helps a couple of areas. It helps to decrease some of the bias. It helps to make sure that as they're going through and putting this out, it gives the faculty member that opportunity to think about whether or not they're doing norm referencing, whether or not they're contrasting different learners because of the order they happen to do things in. you know, by putting that feedback with the learner in the middle between the time that they write that narrative description and the time that they complete the rest of it. Again, it's just an opportunity. It's another way to think about doing this. Now, something that is available, we do have an online assessment tool for direct observation. We also have a direct observation toolkit that I will be showing you when I'm there, that we'll be going through and doing some practice with. What I want you to think about is that even, you know, not suggesting that for everybody to jump out and use this, but if nothing else, you might want to look at the framework that's included in there to see whether or not you have a similar framework built into your own direct observation tools. And then finally, faculty development. Again, faculty actually need to be trained in how to do direct observation. A recent study that came out last year from Jen Hogan and Eric Combo, it showed that we're not as good at direct observation as we thought we were. And so we want to make sure we continue to provide that training. And I love this idea of the bolus and the drip, right? You do the big workshop, right? You know, like kind of like this workshop that we're about to do. But then over time, make sure you have some deliberate practice. During your monthly meetings that you have as a department, add in 10 minutes that's focused only on faculty development, right? Maybe every, you know, once a month, there's a 15-minute huddle of the faculty where they come together and they discuss a particular assessment tool, right? They discuss how they've used a particular rating tool that they've used, or how they're thinking about they might want to change something, how they gave effective feedback. There's a lot of different opportunities here. Now, you're welcome to email any questions to me before I get there. Like I said, I will be there on May 28th, and I am really looking forward to seeing all of you. If you've got questions, please send them. We do have a pretty full program planned for you. Please be sure to select a couple of assessment tools to bring with you to the workshop, because you are going to be doing a deep dive into some of those tools. We're going to be thinking about the 5 W's of assessment. We're going to be applying some principles of competency-based medical education, and we're going to think about some of the principles that I talked about here, so that you can look at your tools and decide whether or not you're applying some of these ideas to them. So I want to say thank you, and again, I look forward to seeing you soon. Bye-bye.